Okay, good afternoon. I'm going to talk about the value of defect closure in ventral incisional hernia repair, and something that I hope will be thought-provoking. So herniasis, it's not just about the midline of the rectus abdominis. With a hernia, the abdominal wall loses synergy with the diaphragm, and the bowels are forced out with respiration, according to Rivas. There's lordosis and back pain because back muscles are not counterbalanced. The lateral muscles retract and become fatty and fibrous, and there's obviously skin changes. So the goals of abdominal wall reconstruction are not just to get the abdominal wall together, but to restore the abdominal wall function. So reattaching the tendons to the lateral abdominal walls has been an objective for a long time. That initiated relaxing incisions and such. When we look at a rodent model of hernia, with a construction of a hernia, there is reduced type 1 collagen and fibrosis. There are actually some muscle changes in addition to the loss of the abdominal wall dynamics. When measuring the return of strength with an isokinetic dynamometer, a pretty expensive machine, you can see that with the controls, there's pretty good abdominal wall strength. With a laparoscopic bridging repair after post-op, there's significantly less strength than with a primary fascial closure repair, but still they're far from normal. We developed a way to measure abdominal wall strength by using a physical therapy metrics, a double leg lowering and an abdominal crunch. And that, according to that, about 99% of people without a hernia have a score of 10 out of 1 to 10. We found that there was some correlation between the defect size and the abdominal wall strength, but it was a really fairly weak correlation, so that the abdominal defect, the biomechanics of the defect, are not responsible for much of the decreased abdominal wall strength. And that the return of abdominal wall strength when retesting people at 4-month intervals after operation was really pretty slow, that it took about a year for people to regain abdominal wall strength, and very few people actually returned to normal strength. We found that in open repair with defect closure, there was actually a significant increase over pre-op, where we did not find that with the laparoscopic bridging repair. And in those patients who had really poor abdominal wall strength, who got component separation, there was actually a period of deterioration at 4 months before they improved. And again, very few returned to normal at a year. So component separation with defect closure is their best chance. Mike Rosen's group studied abdominal wall